Wonderful. And so it is my pleasure to introduce Julia. Julia is a health actuary and health policy professional dedicated to improving the health of vulnerable and underserved populations. Julia currently serves as the Chief Strategy Officer and Chief Actuary for the North Carolina Department of Health and Human Services, Division of Health Benefits, where she leads the Medicaid policy development and analysis, including designing North Carolina's innovative approach to Medicaid managed care, addressing both medical and non-medical drivers of health. Prior to this position, Julia spent 5 years in public and private sector organizations advising state policymakers on implementation of the Affordable Care Act. In addition to being an actuary, Julia holds a master's degree in public health from the University of North Carolina at Chapel Hill. Julia also has 8 years of experience providing healthcare and other benefits consulting to large employers. And we are especially grateful for you being here because we know that there are some major things happening with Medicaid managed care changes right now, and y'all are just extremely busy. So we really appreciate you taking the time, Julia.
Thank you so much, Shar, and thank you all for having me. It's really a pleasure to be here tonight, not just because you invited me to talk about one of my favorite subjects, but also because I know you all are passionate and dedicated advocates for better healthcare in North Carolina. So it's really my pleasure to be here with you tonight. I feel like I need to end that bio with, and Julia really needs to shorten her bio because that was a lot. But I'm really happy to be here with you all. So I was asked to present on Medicaid expansion. I do have a lot of content. I think Shar might jump in a couple times and help just bring in some additional commentary to really tie it to the work that you all are doing. And Shar, if you could also help me keep the time in check, if you want me to move along, just let me know.
Yep, no problem.
I'm going to go ahead and share my screen. If I can figure that out, just give me 1 minute. Okay, did that work?
Yes.
Okay, fantastic. Let's see if I can make it so I can still see you all here. Oh goodness. All right, there we go. Okay. All right, I'm going to jump right in. So for the presentation tonight, I'm going to share with you all some information about our uninsured in North Carolina and our just generally the healthcare coverage profile. We'll talk about Medicaid and what Medicaid does and who we cover today and who we would be covering under Medicaid expansion. We'll talk a little bit about money. I'm the actuary here in North Carolina Medicaid, so try not to get bogged down too much in the details, but stay high level and what hopefully resonates with you all. We'll talk about some of the research around Medicaid expansion and what other states have found in terms of the benefits in their states. We'll touch a little bit on the impact in rural North Carolina, and then we'll give you some background on recent work that we've been doing in partnership and in collaboration with others across the state to and in a bipartisan way to find ways to address increasing healthcare coverage in the state. So we'll just jump in and start with the uninsured in North Carolina. This is based on data from 2019. So this is before the pandemic. And we know that the pandemic has had a lot of adverse impacts on employment and thus healthcare, because as you can see from the slide, many people get their healthcare from their employer. But in North Carolina, based on this 2019 data, we had 1.2 million uninsured North Carolinians. That's a lot of people that are living without healthcare coverage. You can see here from the slide, North Carolina is in blue here. Expansion states on average are in yellow, and then the United States average is in green. And you can see the different coverage types in North Carolina, but if focusing on the uninsured, in North Carolina, our uninsurance rate across all populations is 11.4% of the population. You can see that that's much higher than the US average and much, much higher than the average in expansion states, other states that have implemented Medicaid expansion. To drill down a little bit more on that, just by way of background, Medicaid expansion is targeting adults ages 19 to 64. Individuals over 64 generally have access to Medicare coverage, and the kids under age 19, we cover up to some slightly higher income levels in our Medicaid and children's health insurance programs. And we'll talk a little bit more about that in a few slides. But if you look at the coverage profile here for our 19 to 64-year-olds, it's much worse than the population in total. And so for our 19 to 64-year-olds in North Carolina, almost 17% of them were uninsured in 2019. Again, this is before the pandemic. We think the pandemic could possibly have increased that to as high as 20% of our adult population in North Carolina. Also, just to note that North Carolina has the 6th highest uninsured rate in the country in 2019. So we're not doing great when it comes to covering our fellow North Carolinians. In terms of who is uninsured, I don't think this will come at a big surprise, but our North Carolinians with lower incomes are much more likely to be uninsured than those with higher incomes. So Medicaid expansion targets, again, adults 19 to 64 with incomes under 138% of the federal poverty level. And that constitutes about 34% of our uninsured populations. So you can see here that for those with who have household incomes under half of the poverty level, 24.3% of them are uninsured. For those between 50 and 100% of the federal poverty level, 17.6%. And then you can see it drops down as income goes up, which is what you would expect, that those with higher incomes likely have more access to job-based health insurance coverage. In terms of, this is just another look at how the numbers split out, but the bars in green here are what percent of our uninsured population, that 1.2 million, are in each of these income bands. So almost a quarter of our uninsured are living under the poverty level, whereas about 13.5% of the population in total is under that federal poverty level. So we have a much higher, there's a disproportionate number of uninsured in that lower income range. On the right of the slide here, you can see what's available in terms of public coverage. So a lot of people think, well, if they're under the federal poverty level, don't they have access to Medicaid? And we'll go through the details of Medicaid later, but the answer is generally not. So Medicaid covers people only that meet certain categories of eligibility. You have to be a pregnant mom, you have to be a parent of a dependent child with very low income, very, very low income. It's well below the federal poverty level is the North Carolina income criteria for Medicaid. And even if you have no income at all and you don't have a child and you're not disabled, you're not eligible at all for Medicaid in North Carolina. So even if your income is zero, you cannot access Medicaid unless you meet one of those eligibility categories. So for many of our uninsured living under the poverty level, they don't have access to any public coverage, including marketplace subsidies. The marketplace subsidies start at 100% of the federal poverty level. And the reason that it was set up that way was at the time that the Affordable Care Act was passed, that's Obamacare, some people call it, Medicaid expansion was actually mandatory across all states, and it became optional based on a Supreme Court case. So at the time that the ACA passed, there would have been the full spectrum of coverage. Medicaid would have covered everyone up to, it's actually 133% of the federal poverty level. And then the marketplace premiums or the marketplace subsidies would have kicked in after that. So for the uninsured between 100 and 400% of the federal poverty level, there are subsidies available for private coverage, but it's not free. There are premiums that people need to make to buy into that coverage. And then there's also cost sharing. So those are your copays and deductibles. And depending on your income, those can be pretty significant in a way that the coverage may not be meaningful. Now that's changed recently as part of the pandemic response. For certain of these lower income within the 100 to 400% of federal poverty, there have been increased subsidies, both for premiums and for cost sharing. So there's much more affordable coverage now for this middle income tier because of their temporary increases in subsidies as part of the pandemic response. And then finally, for those under 400% of the federal poverty level, we do have about 13 or 14% of our uninsured are over 400% of the federal poverty level. They're also not eligible for any subsidies or Medicaid generally. Let me just pause there. And are there any questions about this? We're going to go into more detail. But
yes, Julia. How do these numbers compare with other states?
Yeah, so if you look at this past slide, so again, in North Carolina, for our adult population, 19 to 64, almost 17% of them are uninsured in North Carolina. The national average is about 13%. And when you compare North Carolina to other states that have expanded Medicaid, they're at 7%. So our uninsurance rate is more than double that in states that have expanded Medicaid.
But you mentioned that the criteria to qualify for Medicaid in North Carolina are pretty strict. If we expanded Medicaid, it still wouldn't cover a bunch of people who need it, correct?
So it would fill the gap. So when we go back to this slide, so the gap is these folks here under the federal poverty level that don't meet any of our Medicaid categories. They don't have access to any help for coverage.
But
so it would fill that gap. Sorry.
Because they're under the federal poverty level, they don't need to meet those other requirements that you mentioned, like single parents or.
Yeah, if we expand Medicaid, correct. Yeah. And actually, so I'll get there in 3 slides.
Okay, thank you.
Okay.
Julia, I just wanted to share that one of the issues that we've had, and it's been a longstanding issue related to Medicaid, when people do fall into this, what they call the Medicaid gap, we've had community members that have had to, find ways to be deemed disabled, because that was their best option, because they couldn't afford, the other assistance that was out there. Some of this is before even the ACA was in place, but it is extremely limiting as far as your income and what you can do to be, considered disabled in North Carolina. You can't make too much money and things like that. So it really isn't a good way of living, but that is what some people have had to resort to just to qualify for Medicaid.
Thanks for that, Shar. So just to go through who does Medicaid cover. So, and this is from a national perspective, but there are mandatory coverage groups in Medicaid, and then there are optional coverage groups. So all states must cover low-income children, low-income pregnant women, families who have dependent children under certain income levels, age, blind, and disabled individuals who qualify for Social Security income, and low-income Medicare beneficiaries. So folks that have Medicare that are low income, Medicaid can wrap around their Medicare coverage to help pay for copays and deductibles and other things. There are also optional coverage groups. So states can have higher income levels for pregnant women and children. Medically needy as a group, we sometimes call them deductible groups or spend down groups. So they are above the income threshold, but their medical expenditures are so high that they can spend down their income. And so we take out or subtract their medical expenditures to calculate their income, and that makes them qualified for Medicaid, but they have to pay up front that deductible in order to spend down before their benefits kick in. And then the one we'll talk about today is Medicaid Expansion, which covers adults regardless of their category with incomes up to 138% of federal poverty level. So it's all adults. The only exception is around citizenship and residency requirements. So these are our income limits in North Carolina Medicaid today. So for children, we cover children through Medicaid and our children's health insurance program, which we call Health Choice, up to about 210% of the federal poverty level. So There are states that go higher than that, but we cover up to about 210% of the federal poverty level. For pregnant women, we cover pregnant women up to about 196% of the federal poverty level. And we cover pregnant women once they're pregnant and then through 60 days after birth. So it's a temporary short-term coverage that covers pregnancy. For parents, oh, I skipped one, older adults and people with disabilities. So these are, again, the folks that qualify for disability, as Shar said, we cover them up to the poverty level. And then for parents, we cover them to 42% of the federal poverty level. You can see the incomes here. So for parents, if you're in a household of 2 people, so if you're a single parent with 1 child, that means you have to make under $7,200 a year to qualify for Medicaid in North Carolina. And then non-disabled childless adults, we don't cover at all currently in Medicaid. So this is where the gap is. It's actually on the next slide. So these orange bars, these are the gaps that we would cover with Medicaid expansion. So we would cover all of these adult populations. We'd cover them up to that 138% of the federal poverty level. So that's the impact of Medicaid expansion. It helps fill the gap where there's no other help for medical coverage for those populations. Any questions on that? Did that help, Catherine? Okay,
Julia, excuse me.
Yeah.
You may have said this and I may have missed it. Is there an estimate how many people would those peach areas, how the total number of additional?
Yeah, we're estimating that over 600,000 North Carolinians would likely enroll in Medicaid expansion in North Carolina.
Okay, thank you.
So here's a nice map. This shows states that have expanded Medicaid in green and states that have not expanded Medicaid in, I guess it's gray, white, whatever color that is. So there are 38 states, and this became an option in 2014, but there are 38 states plus the District of Columbia that have adopted Medicaid expansion. States have put this in kind of different flavors, but 38 states have gone forward with Medicaid expansion. And we're one of the 12 remaining that have not. There are 2 states, Missouri and Oklahoma, that recently adopted expansion through ballot measures, but they have not yet implemented their programs. So they're in the lighter green here. So we're one of the last remaining states yet to expand Medicaid. You can see there's a lot of consolidation in our region, and then other states sprinkled around the country. So that's where we are in North Carolina.
And Julia, for the ballot measures, I know we had actually looked at that when we saw that 2 other states had done it, but I know in North Carolina, it's not possible to do it on a ballot. I forget what the legal reason is, but for folks who aren't sure what a ballot measure is, it's where the citizens actually voted to pass Medicaid expansion. And so, Julia, do you know, was there, I thought there was a poll done by someone showing that the majority of North Carolinians wanted expansion. And so we thought, oh gosh, could we get it as a ballot measure? But for whatever reason, it's illegal or not legal.
Yeah, it's not an option in North Carolina. Yeah. Just a little bit more about who's covered. So we covered this on the prior slide, but again, this covers our low-income parents at higher income levels, but still below 100%, 133% of the federal poverty level, and then those low-income childless adults. And then, some of those subpopulations, low-wage workers, veterans. We have many veterans who are uninsured in North Carolina and their families, children who age out of Medicaid. So kids, when they turn 19, if they're not below those thresholds and they don't meet the categorical eligibility anymore, they also lose their Medicaid. And then women who would be covered if they were pregnant. So it would cover, periods postpartum after that 60 days that Medicaid ends for pregnancy. It would help support coverage for women before they get pregnant, which is an important time to get healthcare and have access to healthcare as well. Just in terms of the demographics in North Carolina of our Medicaid expansion eligible population. So by age, more than half of our low-income uninsured adults are under 40. So this would really help support some of our younger populations that tend to be more likely to be uninsured. Most of this population is employed. They're working. In terms of race and ethnicity, about half of the eligible population would come from populations of color who've been marginalized historically. And you can see about a third have children and a little more than half are women. Just again, many of these folks are working. This is national data. The earlier slide was North Carolina data, but there has been an effort in some states to implement Medicaid expansion with work requirements. But based on the data, most of these folks are working, or they're going to school, or they're dealing with an illness, or they're caring for a child or other dependent. We pulled out some industries with low wage workers and high uninsurance rates just to show, again, these are working people in, our neighbors, friends, and, especially you can see in some of these industries that were really hard hit by the pandemic, and the hotel and lodging industry and restaurants and daycare workers. They have high uninsurance rates among their workers and low unemployment. So these are the types of folks, working North Carolinians, that Medicaid expansion would help to support. The folks that have, many of which either were struck hard by the pandemic or have supported our response. If you look at, for example, home health workers, they also tend to have high uninsurance rates and low wages. And then we also we have a disproportionate number of uninsured living in rural areas of North Carolina. So we already know, if you live in a rural area, you probably have maybe already some access issues to find care, but they also have issues in accessing and paying for health insurance. So they get the double whammy there, living in a rural part of the state. And so you can see here, the darker blues here are the areas that would most benefit from Medicaid expansion, because they have a higher portion of their population that's uninsured.
And quickly,
All right, any questions?
Well, just about the rural areas. So looking at the people in our database, member database with bleeding disorders, we have a board member who did I guess heat map, or I don't know what you would call it. But anyway, he looked at the community members in North Carolina. We have a lot of folks that live in these rural areas. And for people with bleeding disorders, you need to have access to care. And unfortunately, and Julia, you may be getting to this with the financials, but we've seen hospitals closing down in these rural areas because they can't afford the amount of uninsured people that are coming in, because it takes from their ability to provide care. And so we've seen a lot of concerns. Jean, I see you. Are you on mute? So, yeah, I'm sure you can speak to this too.
Yeah, pardon me if my voice is here. I didn't want to interrupt you, Charlene. I just wanted to speak after you because I am one of those people, but go ahead.
Oh, no, I'm done. I just wanted to make the point that this is especially important to us.
See this little dark area toward the south of the state that's shaped almost like a boot with the toe hitting the east? That's where I am. And I can tell you, in this rural area where it's so sad, it's just so sad. The pandemic has hit all of us, but I am someone with a bleeding disorder who sees this type of difficulty in my town firsthand. So yes, I was just again, I don't feel very well. I don't think I'm articulating very well. I'm sorry.
No, this is great. Appreciate knowing that, you know, again, what we see in our database is correct. What we hear from people is a problem.
Yes. It very, very much is. And we have one itty bitty teeny tiny hospital that I had the non-joy of being in because, not because of the people, but because of how sad it is to see how little they have. And since the pandemic hit, worse.
Yeah.
And, you know, it's the only hospital for all of us anywhere near here. And so, yeah, we are very, very much affected. And yeah, that's all I have
And
to
if
say.
people could get Medicaid and access to insurance, these hospitals wouldn't
Yes,
be at such a loss.
that's right. The people would be helped. The hospital would be helped. The people who work at the hospitals would be helped. The people in the, yes, it would just, a positive snowball effect. If
Exactly.
you
And Julia, looks like we teed it up for you.
Yeah, thank you for sharing your experience. So these are the numbers in North Carolina. So in 2019, our hospitals across the state provided $1.8 billion in uncompensated care. Billion. So that's what our healthcare system has, just our hospitals alone have to absorb in uncompensated care, you know, largely driven by the uninsured or uninsurance, high numbers of uninsured in North Carolina. So we'll talk about other states later, but you know, Medicaid expansion would definitely lower this number and help support our hospitals, especially in rural areas where you saw from that map, most of our uninsured are. In terms of how Medicaid is financed, so Medicaid is jointly funded by the state and the federal government. In North Carolina, for every dollar we put into Medicaid, we get 2 from the federal government. But for Medicaid expansion, for every dollar we put in, we get 9. So Medicaid expansion is the federal government picks up 90% of that cost. In terms of our projections, someone asked about this. We're estimating that more than 600,000 North Carolinian adults would enroll in Medicaid expansion based on studies there are studies that support that. We do expect it will take a little bit of time for that to ramp up. We assume it takes about 2 years to get to that 600,000, but we know that there's the demand out there, especially now for health insurance. In terms of the financial projections, we estimate this will bring in a lot of money, a lot of federal money for the state. So after that 3-year, the ramp up by year 3, the total costs are about $5 billion, and the federal government pays 90% of that, and the state, the non-federal share is $500 million. And there are several ways that that we could pay for that $500 million without having to increase taxes on North Carolina citizens. So we can touch on that if y'all are interested. Here, it's here. So several states have used various ways to fund this. Taxes on health plans. So the health plans will get more membership in Medicaid, and we're moving to managed care, and so they get more membership, and we can tax them to help support this. We know that the hospitals will have large benefits. We have assessments on hospitals now to support some of their payments under Medicaid and in the regular Medicaid program. And so that's something we could do to support expansion. And you know, the leveraging effects are large because, again, for every dollar, we get 9 back in federal money. There are other offsetting savings for other programs. We have, the state puts money into behavioral health programs for the uninsured. And so this would bring in federal money to help support that. That could offset some other state programs. The criminal justice system, this would open up Medicaid coverage for hospitalizations for individuals who are incarcerated. And then there are other savings as well. So they're offsetting savings to support funding this. And then the big one is, as part of the recent American Rescue Plan Act of 2021, which is the latest pandemic response bill, it created a very, very large incentive for new Medicaid expansion states. So for states just like North Carolina to expand Medicaid. And it's a little bit of odd math, but what they're doing is they're saying, if you expand Medicaid for these states that haven't done it yet, they're going to increase what we get on our current Medicaid populations by 5%. So they'll increase our federal share on our current Medicaid programs by 5%. And for North Carolina, that generates $1.7 billion of new federal revenue. So if you compare that to the non-federal share, that could pick up this $400 or $500 million for a few years. So it's basically makes Medicaid expansion free, at least temporarily, but then the 90% match continues. So this would be a big benefit for North Carolina if we chose to expand. All right. Any questions on the numbers? I know this is a lot fast.
Julia, the argument that the naysayers are putting forward is that they don't want to contribute to the federal deficit and so forth and so on. But at the same time, aren't North Carolinians who pay their federal taxes losing out on what they contribute to the federal revenue by not getting this back to North Carolina?
Yes, our taxes are funding other states who have done this.
Right. So our legislature is pretty much saying, we don't care that you are paying into this, you're not going to get anything out of it. So our money is pretty much going down the tubes, those of us who pay federal taxes, which is everybody.
Yes, we're not getting the benefits that are available to the state through this program.
It's going somewhere else and not back to us.
Okay, there's a lot in these 3 slides, so I apologize, but some of the impacts of Medicaid expansion, and many of these come from research in other states. So Medicaid expansion increases coverage for low-income individuals and vulnerable populations. It helps reduce disparities among our historically marginalized populations, helps low-income workers, individuals with mental illness and substance use disorders. There have been many studies showing how Medicaid expansion can increase the use of preventive care, which really helps with supporting those with chronic conditions. Primary care appointment availability increased in some states. I don't need to read through all of these. There have been reductions in marketplace premiums in states that have expanded Medicaid. So there's support for affordability in other parts of the healthcare system by implementing Medicaid expansion. It helps with medical debt for folks that have to pay large out-of-pocket amounts because they don't have insurance. Well, this helps with that. And then we've talked about uncompensated care for hospitals, clinics, and other providers that are seeing uninsured patients. Health outcomes. So self-reported health outcomes have shown improvements in states with Medicaid expansion, reductions in mortality. So it supports people living healthier lives. Again, increase in health status, and that's from a study in Kentucky. Infant mortality rates declined in Medicaid expansion states, and infant mortality is a big issue in North Carolina. We do not perform well relative to other states. Improvements in mental health, and also helping to address the opioid crisis and overdoses. Improvements in access to medications and other treatments for mental health and substance use disorders. And then there's some hard data here from Kentucky. They saw 300 new behavioral health providers see patients in their Medicaid program, and they were able to provide substance use disorder services to 13,000 more people. Medicaid expansion helps the economy by improving the labor market. Healthy people can work much more easily than unhealthy people. It's helped with job creation by creating new jobs in various sectors, and economic growth, helping with poverty rates and food insecurity. Here, Pennsylvania saw a $2.2 billion increase in economic output. So there's a very strong financial case to make around Medicaid expansion as well. We talked about, there being offsetting savings in other parts of state budgets because there are state funds being used to pay for part of the uninsured care, but in bits and pieces, not in a comprehensive way. Any questions on those impacts? And I can share these slides with you all because I know it's a lot.
Yes, I'd love to have a copy of these slides before the legislative day.
Sure. I see a thumbs up from Jean too. Okay, we've talked a little bit about rural. This is that map again, but also some other important statistics. So our rural residents are 40% more likely to be uninsured and eligible for Medicaid expansion. Medicaid expansion improves hospital financial performance. So again, helps reduce that uncompensated care, brings economic benefits to those hospitals and thus those rural areas as well. We've had 11 rural hospitals close in North Carolina since 2005, and we have 6 more that SHEPS is a research center at UNC, 6 more rural hospitals that they're classifying as high financial risk. Those hospitals serve about 180,000 people. And then losing a hospital can translate into lower per capita income for that area as well. So very big, significant economic problems where rural areas have lost a hospital.
And again, just driving that point home of, I mean, if you're already in a rural area and you have a bleed and the closest hospital to you closed, I mean, that is the difference between life and death in some situations. So this is one of the many reasons why it is so critical to expand for our community.
Thanks, Charlene. This again just shows kind of a similar point, but in states that expanded hospitals, states that expanded Medicaid, I'm tired, I don't know about y'all. In states that have expanded Medicaid, there has been this decrease in hospitals that have closed. And in states that have not expanded Medicaid, there has been an increase in hospitals that have closed. So again, just driving home that same point as the last slide. And then just to close with the work that we've done recently. So in December and January, the Duke Margolis Center for Health Policy convened a North Carolina Council on Health Coverage. It was a bipartisan group. It included legislators and business leaders and advocates and healthcare providers and insurance leaders. They all came together to talk about how to increase coverage, healthcare coverage in North Carolina. And there were several ideas that were discussed. Medicaid expansion was among them. And what came out of the council was a set of principles for North Carolina for expanding coverage. There was not consensus. I'm sure you all aren't surprised in a bipartisan group. There wasn't consensus that everyone wanted to do Medicaid expansion, but there was consensus around a set of principles that include maximizing coverage, efficient use of tax dollars, program simplicity, the health of North Carolinians, sustainability, addressing rural issues, addressing health disparities, behavioral health was a big theme, the support of businesses and the support that coverage expansions provide businesses like that healthier workforce, and then healthcare access considerations that was mostly around telehealth and making sure that that everyone had good access to healthcare. So I'm going to close there and see if there are any questions. There, we do have the link here. If you want to see some of what I presented today actually came out of some slides that the department presented at the Coverage Council, but there's a lot more information out there about Medicaid expansion. I believe all of their meetings were recorded, and there were some representatives from other states as well that that talked about their states Medicaid expansion experience and expansion and other coverage initiatives. We do also have a meeting tomorrow. You can find information on the Duke Margolis website. So again, it's all in the slide, but the meeting is tomorrow afternoon. I believe it starts at 3 o'clock. And so we'll be continuing the conversation, and we'll be hearing from Michigan and business leaders who recently formed their own roundtable. I think it was called a roundtable, their own group to talk about healthcare coverage, since it's, I mean, it's always an important topic, but in the midst of this pandemic, it's just escalated in terms of the urgency of addressing it. All right, now I'm going to stop. Any questions?
Yes, I do. I have a question. What time, wait a minute, legislation day. I have all day marked out for that on the 25th.
So
What? Yes.
Well, so what the plan is, if you're willing to meet with your senator and or representative, Jillian is connecting with folks who register for Legislative Day. Phil Poovey, who's our vice president for our board, he is working with attendees to connect with their senator and their representative to set up meetings for whatever time works for both schedules. So, so for now, if your schedule's open, please keep it open if you can, and then that way you'll have the most flexibility for the meetings.
Yeah, that's what I did.
That's how it's going. Yeah, perfect.
Okay.
I have a couple questions for Julia. Are veterans covered by the VA, or do they have to pay for their coverage?
You know what? I will have to follow up on that. I don't believe all veterans qualify. I don't know if it's based on number of years, but I can find a little background and send that to Charlene to share with you all.
Okay.
Unless someone else, maybe someone else on the call knows the answer.
My other question is, how much is North Carolina paying for Medicaid right now?
So our Medicaid program is about, well, it depends. It's a good question. In 2019, the program was about $15 billion, and the federal government pays about 2/3 of that. So the federal government pays about 10 million of that 15 million. And then we have some provider assessments that pay for some other pieces of it. So the state puts in, I believe it's between $3 and $4 billion. And then the rest is funded through other ways, with mostly federal money.
Okay, so we are using federal money now, anyway.
Yes. Yes, we are using federal money. Yeah.
I just wanted to share that Tricare for veterans, depending on if they're active duty, they have coverage. If they're not active duty, then if they're retired, like my daughter, she has to pay, even though she's retired and she's able to go on post and see the doctors, her children have to pay, she has to pay for insurance extra. It's a monthly payment that she pays for insurance.
So she's paying for her children or for herself as well?
No, she's paying for her children.
Thank
She
you.
doesn't have to pay for herself because she med boarded, so she's covered.
Thank you.
That's, I mean, you know, that's a little bit that I know, but I'm sure there's some more stuff that we can look at.
That helps.
Thank you.
Thank you.
Yeah, thank you, Carol.
You're welcome.
Any other questions for Julia?
Yeah, Kathy here. I am just curious to know if, Julia, if you have your, your finger on the pulse of our legislature. They have been intransigent about this issue. It's really frustrating to me. I live in a very liberal county, Durham County, where I don't even need to talk to my legislators. They are so much in favor of Medicaid expansion. And so I'm at a loss when you've got doctors and hospitals and patients and actuaries and the whole world who sees what a benefit this will be to North Carolina, and it's our own money that we've sent to the federal government. Do you have a feel at all for what might move this issue forward any?
That is a really good question. I wish I knew, because I feel like, we at the department, we've been advocating for this for.
And I know it's a delicate.
Since the governor, we've tried every argument we can find. So I think it's about the messenger. I think if we can get the right people, I hate to say that because we all want to be the messenger, right? But to find the folks in the business community, to just really talk about the economic benefits or really the economic detriment of not doing it.
Well,
I don't know. I'm going to see if Charlene wants to. If Charlene wants to add anything, so I punt it back to you.
No. The slides that you've provided really help me to put this together and advocate maybe even a little better. I kind of wish I lived in a more rural county and had intransigent legislators for my legislators and could just go sit down with them.
Well, and one thing that you can do, Kathy, is for legislative day, if you're available throughout the day, if you can help Jillian and me to sit in some, virtually sit in any meetings with folks that do live in these areas.
Would love to do that as long as I have Julia's slides in front of me.
Yes, we'll make sure to get them out to everybody.
Okay.
And it's politics. I mean, there's some who are just simply not gonna agree to it because they refuse to agree to it, no matter what the arguments are, no matter what the facts are. But there are people, like Julia had mentioned, about some of the business leaders and stuff like that. And in the couple of years that, I think it's 6 years now that we've been pushing for it, in the meetings we've had with Medicaid and with the governor's office, and working with other organizations, first of all, they have to hear from us. They have to hear from their constituents because we are who vote them in or out. So that is number one. So don't discount your voice. But then the other thing too was, especially these rural counties, yes, business leaders, farming bureaus and things like that, people who can help or hurt the economy in these local areas and that have influence in these areas are really important. So, thinking about if you live in one of those areas or know folks who do you have any connections, whether firsthand or maybe through a friend who you could help and talk to and just share your story or share the story of someone else. I don't have a bleeding disorder, so I can't necessarily relate firsthand to the scare of not being able to get to a hospital in time when I've been in a car accident because I don't have a bleeding disorder. But I can tell you that it's really important to me because I have so many friends in this community that is their reality right now.
From an economic standpoint, you would think everybody would be in favor of this, and it's an ideological question, and that's all it is.
Yep.
And we're just on the wrong side of ideology right now in North Carolina, along with all the other southeastern states, it looks like to me.
Yep.
So how about the strong voices of hospital administrators in these rural areas whose facilities stand to be closed, or the voices of physicians in those areas who could help advocate for the rare disease community? The bleeding disorders community, of course, being part of that, but just the rare disease community as a whole, because the other thing I've been thinking the whole time is how quickly families who manage rare diseases fall into that medical poverty situation because you blast through your caps so early in a year. And, that's just been sticking with me throughout Julia's presentation. But if we could get some of those strong voices from the medical community in rural areas, that may also help.
And Rachel, I agree with you. And I think that those voices probably have been screaming for 6 years. Those very voices.
Yeah.
I know at least some of them have, because we worked with them. I don't know if it was last year or 2 years ago when we were really trying to make a push. And there were a lot of associations that were signing on to our letter.
I mean, I do think it's encouraging that we did have people come to the table for the Coverage Council.
Yes.
So I think that this is a critical moment in the debate. I think that this year it's just different because of the where we are with the pandemic. So I would say I didn't mean to discourage anyone. I mean, I think this
No,
is
you didn't.
just, this is a good time
Yes, it is.
to be fighting for.
So Julia, my question for you then is, what is the time frame here? Is it a continuum, or each year do they have to decide by budget day or whatever?
Yeah, I mean, they are typically working on a timeline. They can come back for special sessions. Others may be able to describe the legislative cycle better than I can. I don't know when they're planning to leave this year, but they always say they're going to work faster than they do. Oh gosh, this is recorded.
Oh, they know it.
Yeah.
So we'll look at that, Kathy. I know there's some bills. I'm trying to think, and Jillian, I don't know if you remember off the top of your head what the crossover date was.
It's
I have
this
it in my
week.
notes. It's this week, right? Okay.
Yes.
Yeah. So a crossover date is where any bills that the Senate wants to pass have to go over into the House for review and vice versa. And otherwise, my understanding is the bill isn't going to happen. So I know that there's a few right now related to Medicaid, but I don't know specifically what's out there because we kind of wanted to see what picks up in the legislature, what kind of starts to look like it's possible. So we'll be looking at that before legislative day when we're writing our talking points.
And I know the governor's on our side, and he could veto it. I think he did last year because of that. But that's not a good way to go forward either.
No. Any other questions?
Julia, that was excellent presentation. I can't wait to get your slides in my grubby little hands.
We'll send them out tonight to Charlene.
Absolutely. Thank you so very much, because that was a wealth of information. I can't wait to have that information too.
Thank you so much.
Excellent. Thank you very much, Julia. And again, please, advocacy is year round. We need more advocates in this community. I mean, we need more advocates in general. I see so much that goes on local, state, and federal level that I don't know that most people know what's happening. But there are things that in the bleeding disorders community especially are essential. Healthcare is one of them. Access to medication is one of them. Access to, hospitals and care is another one. So please join us for virtual legislative day. If you're not already getting your emails we have a monthly advocacy call. It's the first Tuesday of every month at 7 p.m. It's a conference call. You don't have to have any advocacy or legislative experience. We break things down. We try our best to make sure that we don't use acronyms that may or may not make sense. We take notes. So please get involved to the extent that you can, even if it's just getting on that email list to start getting the advocacy calls and joining once in a while when you can. But we need your voices for this generation and for the future generations. So thank you all very much.
I have one more question.
Thank you.
Yeah, of course.
I heard Julia mention, I messaged you, Julia. Thank you so much for a wonderful presentation. And thank you to everybody who helped answer questions. I learned a lot. But I did have one more question. I heard, Julia, that you mentioned something about having a meeting tomorrow. That might have been a meeting that you were having with someone on your end, but is there something that I forgot to sign up for?
Let me find it, and you know what, I'll put it in the Zoom chat. Just give me one
I know I'm
minute.
planning for the 24th for the night before legislation and for the 25th, but I just didn't know if I missed it.
Yeah, and so what she was talking about, so it's a collaborative bipartisan effort that a bunch of people from both sides of the aisle and from other states are meeting to talk about the issue of access to healthcare. And so that's what this meeting tomorrow is. So, you know, it looks like Julia put the link in the chat, and I'll try to.
The meeting is from 3 o'clock to 4:30 tomorrow, and it's open to the public. if
So
you wanna
we'll
listen
send
in.
this out with the slides before that time tomorrow for anyone that just wants to sit and listen in, because I'm sure it's a very, I've heard of this initiative already. I thought it was great when we heard about it, and I do believe that the things have been recorded, like Julia said, but I'm sure it is probably very interesting to listen to as well.
Great.
Bless you.
Thank you.
You're welcome. Well, great. Well, thank you again, Julia, and thank you to everybody for attending. I look forward to advocating more with you.
Thanks, everyone.
Thank you. Have a great night.